We have described this procedure in a different lecture. Here we point out that the present value of the outlays in the next 5 years is estimated to be $73,973. The analysis is accurate in the sense that it has accurately built the purchase price of an electronic health record from the engineering specification of what is needed. The analysis is not accurate as it hasn't gone beyond purchase price and calculated other costs related to housing of the computers, costs related to operating systems, and costs related to managing the information. It also hasn't kept in mind the potential impact of the electronic health record on efficiency of operations. Putting aside costs of impact on operations, are we reasonably assured that these are all of the costs? No, because when you build cost estimates from the bottom up, you almost always ignore the costs that are not associated with any activity per se. People do not always work. Sometimes they go on vacation, and other times they are idle, for example, when the patient does not show for her appointment. To only track cost of time of an activity underestimates other costs related to setup and closing of an activity. A phone call may be 2 to 3 minutes, but the task of recovering from the call and getting ready for the next one will also consume time. These types of related activity costs are almost always ignored in approaches that build up cost from bottom up. In activity-based costing, the analysis starts from the total organization's budget, which includes many costs not linked to specific activities. For example, it includes the cost of a patient making an appointment but not showing. Or it includes the benefits paid by the organization to current retirees. These are all real costs of businesses and should be included in costing out various activities carried out by the business. Imagine a clinic with 3 physicians, a laboratory, and a radiology department. It has various costs. This view shows the cost per month for labor, rent, utilities, insurance, office supplies, advertising, telephone expense, and equipment costs. For the sake of this example, assume that the physician's payroll is not included, as they would divide the clinic's profit among themselves. The question to answer is, what is the cost per visit before implementation of an electronic health record system, and what is the cost after? The first step is to allocate the monthly expenses to various doctors and revenue centers. The direct salaries is distributed based on the time that the nurse spends with each of the doctor's patients. The payroll for supervisors and administrators is allocated based on number of full-time equivalent people they manage within each cost center. The advertising cost is divided equally among the physicians. Rent and utilities are allocated to the cost centers based on the square footage each cost center occupies. Office supplies is divided equally among the 3 physicians who use these supplies. Insurance is allocated proportional to number of full-time clinicians working within each cost center. Telephone and equipment is allocated based on clinicians who directly use these services. Dividing the total cost for each physician by the number of visits per physician, one can estimate the cost per visit for each physician. Note that in this example, 2 physicians have a relatively high cost per service and one has a lower cost structure. Now let's see what happens after an electronic health record is introduced. For the sake of the exercise, assume that the administrative personnel and office supplies go down because we no longer need the clerk that was working with the paper records. Office utilities, telephone, and equipment costs go up. Also note that the number of visits for each of the physicians drops between 5 to 10%. This shows the resulting cost structure after the implementation of the electronic health records. Administrative payroll and office supplies have been reduced by 2/3. Other costs such as utilities have gone up modestly, and there's been a sharp increase in equipment cost. Also note that the number of visits to various clinicians have dropped modestly for the first 2, but significantly for the 3rd clinician. What is the net impact of electronic health record on the cost of this clinic? As before, we allocate the expenditures across various cost centers. We calculate total costs for each cost center and divide by the number of visits to calculate cost per visit. The cost per visit is calculated to be $10 for Dr. A, a small reduction from before. The cost per visit from the clinician B has increased by $1 per visit. The same has happened for clinician C. There's been an increase in cost by $1. The advantage of activity-based costing of electronic health records is that it shows the impact of all costs and not just directly trace costs. So if implementing the electronic health record reduces administrative payroll but increases other costs, activity-based costing shows the net impact of this change. It also shows the impact of electronic health record on volume of the service. If the information system is cumbersome and reduces the physician's efficiency, then as this example has shown, activity-based costing will show an increase in cost of delivery of care. This will be the case despite the savings in payroll that might come from needing fewer medical record personnel. This presentation has tried to show you how a project manager might estimate the cost of an activity. One method is building costs from bottom up, and the other from the top down using the organization's budget. The latter method is called activity-based costing, and it is an effective method of estimating costs of electronic health records.